the time. Good afternoon. Welcome to Wonderful Wednesday. And today what we're going to talk about is the triple blocks. So here I'm going to talk about triple blocks. That's typically first degree AV block plus left anterior fascicular block plus right bundle branch block. Some people in the audience are like, oh my God, fascicular block. What is that? Don't worry. I'm going to help you understand it. And that's always my goal. So if we just take a look at this patient, you will see at the top of this patient's EKG, you're certainly not going to see any identifying information for the patient. But what you see is it says bifascicular block. That means that of the three electrical pathways that activate the heart, the first one being the left main, oh my goodness. So the first one being the right bundle, the second one being the common bundle of His. I said left main because it's kind of the same idea. The common bundle of His that then separates into the anterior division, known as the anterior fascicle. That activates the front of the left ventricle. And then the posterior division, that goes around the back part of the left ventricle. So, right, the left ventricle is bigger in the normal process. The left ventricle is bigger. It requires more electrical activation. And we activate the front and the back of the heart at the same time. And so those two things cancel that, the visualization of them as an independent process. That cancels it out. The right bundle is the only bundle that goes to the right heart. And remember, normally you're going to activate your right heart first because it's thin-walled. The right bundle moves rapidly. And then you're going to activate the left ventricle second. And it's going to take longer. It takes a little more time. It takes a lot more voltage because the left ventricle is really massive and big. So when we just take a quick look at this EKG, there are a couple of things that are going to be important. We're going to talk about all of them and how it relates to understanding what's happening for your patient. So first and foremost, when I look at this EKG, I'm going to remind you, if you haven't ever heard before, that when you are looking at frontal plane leads, that would be 1, 2, and 3, AVR, AVL, and AVF, what you anticipate and expect to see is the majority of the electrical current is going towards the left side. So any lead that has a positive electrode on the left side, that would be 1, AVL, leads 2, 3, and AVF, and the frontal plane leads, those pictures should always be upright. Okay, those pictures should be upright. So I expect lead 1 to be primarily upright. I expect lead 2 to be primarily upright, lead 3 to be primarily upright, not AVR, because that's the right-sided electrical, AVL to be primarily upright, and AVF to be primarily upright. So do all those leads point in the upright direction, yes or no? Unless you're not looking, you would say no, okay? You have upright in 1, you have upright in L, but in 2, 3, and AVF, you have a downward configuration, which means this is abnormal, okay? This is abnormal. Just looking at frontal plane leads. What you're going to use is 2 leads that basically bisect the chest, basically, and that would be lead 1 and AVF. Lead 1 should be upright, AVF should be upright, and if they're both upright, you have a normal axis. So we have an abnormal axis. We're going to talk a little bit more about that in a minute, which is you have to explain that. Why do I have an abnormal axis? And the reason, there are 3 basic reasons for abnormal axis. Hypertrophy, bundle branch block, myocardial infarction. That's it. Hypertrophy, bundle branch block, myocardial infarction. Are there other causes? Yes, but for our purposes, that's going to work really well. Okay? So in addition to that, we're now going to go over and look at our chest leads. And when we look at our chest leads, what we're going to look for is the massive direction. In a normal V1, it should massively be downwards. In V2, with a small upright and massively downwards. In V3, you should have an upright and a downwards that are relatively equal. And V5, V4, V5, and V6 traditionally are going to have mostly upright. So small, bigger, bigger, big, big, big. That's what you're looking for in terms of the R wave. But when you look here, you can see that V1 is primarily upright. That is absolutely profoundly abnormal. We're going to talk about why. So when you look at an EKG, there are really some simple strategies in terms of how we're going to look at our EKG. Now, I want to talk in this case, as we're looking at this patient and that EKG, about a couple of things. First of all, your patient has first-degree AV block. His PR interval is greater than 0.20. Secondly, he has right bundle branch block. Thirdly, the anterior division of his left bundle is also not operational, and that's called the left anterior fascicular block. That means he has 3 different types of block. Why do you care about that? Because that puts your patient at risk for syncopal episodes, sudden cardiac arrest, and sudden cardiac death. All you had to do was really look at the EKG and understand it to know why your patient is at risk. So this is the patient whose EKG we just looked at, right? And this patient is admitted. He's admitted to the emergency department, and he has a heart rate of 72 with blood pressure 160/99, 100% on room air, 100% sat on room air. He's quite diaphoretic, and they do that EKG. He's got first-degree AV block. He's got left anterior fascicular block and right bundle branch block. And the worry is that he comes in because he's had multiple syncopal episodes. Ding, ding, ding. This patient is at risk for complete heart block. And what that means is you, as bedside nurses, hang on one second, okay? Hang on one second. So she's already done? Okay. Okay, hang on one second. I'm so sorry, my friends. I'm so sorry. I'm sorry, my friends. So I'm just saying goodbye to my class, but fantastic. And what I'm going to do now is I'm going to stop the recording because I paused. So no problem. I'll do it again another day and another life, I'm pretty sure. Okay.